Picture this. You've got a patient sitting in your clinic, and they're describing this really strange numbness. They tell you it started way down on their toes, and it's just slowly creeping up toward their ankles. But here's the catch. Their fingertips, they feel completely normal. So you ask them to close their eyes and touch their nose. Boom, they do it effortlessly. Left hand, right hand, no problem. But the very second you ask them to stand perfectly still with their eyes shut, they sway. They almost fall right over. It's a fascinating clinical puzzle, right? Well, every single one of these details, the numb toes, the perfect finger coordination, that sudden loss of balance in the dark, is actually a direct, entirely predictable consequence of one simple, unyielding anatomical rule.
Okay, let's dive into this. Welcome to this explainer on peripheral neuropathy. Today, we're going to mentally light up the glowing, high-tech neural pathways of the human body to decode one of the absolute clearest examples in medicine of anatomical vulnerability. We are building our understanding strictly from first principles today. We're going to look at how the actual physical length of our nerves dictates exactly how and why they fail.
Here is our roadmap for the explainer. We'll start with the rule that the longest wires fail first. Then we'll break down large versus small fiber damage, how diabetes destroys these nerves, important screening protocols and alternative causes, and finally, modern management, including some incredibly futuristic magnetic therapies. All right, section 1, the longest wires fail first. Now, I want you to picture the nervous system. Don't just think of it as a set of static wires, right? Think of it as this highly active, intensely metabolically demanding energy transport system. It's running all the way from your spine all the way down to the very tips of your toes. And this brings us to a concept called the dying back process. You see, peripheral nerve axons depend completely on their cell body, which is sitting way up in the dorsal root ganglion. That cell body has to continuously pump proteins and organelles down the entire length of the nerve. It is a massive energetic undertaking. So, the longer the axon, the further that transport has to travel, which makes it incredibly vulnerable to literally anything that disrupts its energy or blood supply. When the energy fails, the nerve doesn't just stop working. It literally begins dying back from its furthest endpoint. And that exact mechanism perfectly explains the classic stocking glove distribution you hear so much about. The absolute longest nerves in the entire human body are the ones traveling all the way down to the toes. Because they are the longest, they're the most vulnerable. So they fail first and they fail worst. Symptoms almost universally begin in the feet and slowly ascend. But what about the hands? Well, think about it. The wires running down your arms are just significantly shorter. They only get dragged into the disease process much, much later, which is why the hands show a shorter, milder pattern compared to the legs.
Moving on to section 2, large versus small fiber damage. Now, what's really interesting about this is that peripheral nerves aren't just one uniform giant cable that fails all at once. Different fibers do completely different jobs, and they present with genuinely different clinical pictures when they get damaged. So let's compare them. Large fibers, they carry vibration sense, proprioception, which, is your body's internal sense of where it is in space, and motor function. Remember our patient from the beginning, the one falling over with their eyes closed? That is a positive Romberg sign, and it happens specifically because large fiber damage destroys that proprioception. They can balance with their eyes open by using visual clues, but you take the vision away, and they fall. You'll also see a loss of ankle reflexes pretty early on. Now, on the flip side, small fibers carry pain, temperature, and autonomic function. When these guys are damaged, patients don't just feel numb. They feel this painful burning, tingling, or electric shock sensation, and it is notoriously worse at night. They might even get autonomic dysfunction like reduced sweating or resting tachycardia.
Okay, section 3. Let's look at exactly how diabetes destroys these nerves. So diabetes remains the single dominant global cause of peripheral neuropathy. To put that into perspective, we are talking about over 500 million people living with diabetes worldwide, and up to half of them will develop nerve injury over the course of their disease. But how does excess sugar actually cause a mechanical nerve failure? Well, it essentially builds up across 3 parallel destructive pathways. First up, microvascular disease. Chronic high blood sugar damages the vasa nervorum. Those are the tiny blood vessels supplying the nerves, literally choking off the blood supply those long axons so desperately need. Second, you have polyol pathway activation. Excess glucose gets diverted here, and that severely depletes the cell's protective antioxidants. And third, advanced glycation end products, or AGEs, accumulate over years, directly damaging the structural proteins right inside the nerve. It's like watching bright neon pathways slowly dimming out from the toes upward, as all 3 of these mechanisms simultaneously attack your longest, most vulnerable fibers.
Section 4, screening protocols, and alternative causes. While diabetes is absolutely the heavy hitter, when we pivot to a clinical detection, we have to be really careful not to anchor solely on a diabetic diagnosis when a patient comes in with numb feet. Just take a look at this broader differential. If a patient's symptoms are progressing unusually fast or they just don't fit that classic stocking glove pattern, you have to look elsewhere. You've got things like vitamin B12 deficiency, alcohol toxicity, accumulated toxins from chronic kidney disease, or even chemotherapy-induced damage. But I really want to highlight CIDP here, chronic inflammatory demyelinating polyneuropathy. Unlike the slow dying back process of diabetes, CIDP is demyelinating. It can affect proximal muscles, and crucially, this is the big one, it is highly treatable with immunotherapy. That makes it a diagnosis you genuinely do not want to miss.
So the crucial point is knowing exactly when to screen your diabetic patients so you can catch these changes before they become severe. The American Diabetes Association lays out a very explicit timeline for this. For patients with type 2 diabetes, they've often had silent disease for years before they even know it. Because of that, up to 30% already show nerve injury early on. So you screen them immediately at diagnosis. Type 1 patients, though, have a different trajectory, so their screening begins 5 years after their diagnosis. But for both groups, once you start, you absolutely must perform these screenings annually.
And honestly, the beautiful part about all of this is that the screening is refreshingly low-tech. You don't need expensive electrophysiology as your default. A careful patient history, a simple 10-gram monofilament test to check for protective pressure sensation, a 128 Hz tuning fork to test those large vibration-sensing fibers we talked about, and just some basic ankle reflex testing. That is your core annual assessment. The complex nerve conduction studies and electromyography, those are strictly reserved for the atypical, asymmetrical, or rapidly progressive cases we just went over. Finally, Section 5, Management and Axon Therapy.
This brings us to the final stage of our first principles journey. Once those nerve pathways have actually started to dim, how do we manage the damage? Well, we have to start with a bit of a hard clinical truth. Based on landmark trials like DCT in type 1 and UKPDS in type 2 diabetes, strict glycemic control, alongside structured exercise and meticulous foot care to prevent ulcers, is really the only reliable way to alter the trajectory of the disease. Right now, no currently available therapy reliably reverses established nerve damage. Treatment of painful neuropathy is fundamentally all about symptom management and protecting the patient's quality of life.
When it comes to managing that awful, burning, electric pain from small fiber damage, international guidelines generally converge on these first-line treatments. You have oral options like amitriptyline, duloxetine, pregabalin, and gabapentin. The right choice just depends on the patient's other health conditions and their side effect tolerance. Now, for patients who want to avoid systemic meds entirely, the capsaicin 8% topical patch is a brilliant FDA-approved first-line option. But I need to be explicitly clear about something that is not on this list: opioids. Because of a severe risk-benefit imbalance in this specific chronic pain population, opioids are absolutely not recommended. Just don't go there.
And this brilliantly illustrates exactly where the future of pain management is heading. We are finally moving beyond oral pills and into genuinely novel, high-tech, non-pharmacological interventions. For example, we now have 10 kHz spinal cord stimulation showing some really great results for refractory cases. But even more exciting than that is axon therapy, which just got FDA approval in 2024. This is a completely non-invasive, opioid-free peripheral magnetic nerve stimulation technique. It literally uses brief magnetic pulses to manage the nerve pain. It is incredibly futuristic.
And the data backs it up. In recent trials for this magnetic axon therapy, an absolutely incredible 71% of patients achieved meaningful pain relief when it was added to their regimen. 71%. I mean, compare that to just 13% of patients who got relief on conventional therapy alone. It's a massive, game-changing leap forward in making the pain of peripheral neuropathy actually bearable for folks who have been suffering for years.
So as we wrap up this explainer, I want to leave you with one final critical thought. We've spent this time establishing the core anatomical rule, right? The longest, most metabolically demanding nerves fail first, and they ascend slowly from the toes in that predictable stocking glove pattern. But the very next time you hear a patient describe numbness, I challenge you, don't just passively accept diabetic neuropathy as the answer. Actively question the entire clinical picture. Ask yourself, does it perfectly fit the dying back pattern? If it's asymmetric or if it's moving incredibly fast, could it be a highly treatable condition like CIDP that we're entirely missing? Catching those nuances, armed with nothing more than first principles, a simple tuning fork, and a questioning mind, is absolutely the most powerful tool you have. Thanks for joining me on this explainer.